Hello, welcome back to the Dr. Mandy DCN podcast. My name is Dr. Mandy, and I am back after 8 months. I had the baby. Yay! It's official, and he is a handful, but I am definitely here to start educating you guys again on various topics, and I'm also getting into fertility now as well. But today we're going to talk about bladder pain syndrome. So I've got my favorite, Ruth Kriz, here. I'm going to do a quick introduction and I'm going to let her speak after. So Ruth is a nurse practitioner and she has dedicated over 40 years to identifying the underlying factors contributing to the cause and treatment of chronic UTIs, urinary tract infections, and interstitial cystitis, bladder pain syndrome. She has built upon biofilm research by Bill Costerton and hypercoagulation testing by David Berg and discovered the connection between a person's genetics and the propensity for chronic infections, UTIs, IC, prostatitis, long COVID, PANDAS, and others. And I did do a blog on hypercoagulation and a video for those of you who are interested in learning more about that. She closed her practice in 2021. By the way, she was also my practitioner when I was going through IC treatment. But she did close in 2021 and is now focused on educating practitioners to be equipped to address not only the biofilms made by the person, but ones generated by the pathogens themselves. Welcome, welcome, welcome.
Thank you so much, Mandy. It's really a delight to answer some questions that I know you've had and many of your patients have had, and help everyone understand that these conditions, which seem chronic, can be treated and people can get off that merry-go-round that never seems to stop of the symptoms recurring sometimes every month, sometimes more frequently, and sometimes never really totally going away.
Yeah, so I think there's going to be a lot of people who don't really know what IC is. It's relatively new to them. Maybe they just got symptoms, and so maybe they've newly diagnosed. Can you just explain what is IC? Because a lot of times when they're given the diagnosis, it feels really vague. Can you explain that?
Well, that's because it is vague. It turns out that when you failed a couple of courses of antibiotic treatment for your urinary tract infections, they do a urine culture and nothing shows up on the culture, but you're still symptomatic. They don't know what to do with you, so they have come up with a new label called interstitial cystitis that you now fit some of those diagnoses of exclusion. They've said it's not an infection because you didn't have a positive culture and it didn't respond to antibiotics. And so they say you have this strange, mysterious syndrome with no known cause that's chronic, degenerative, and incurable. Hand you a diet and say, have a good life. It used to be that they would do a more thorough workup. They would take you in and under anesthesia, do a biopsy of your bladder wall. And when they looked at it, they would see a lot of mast cells, a lot of inflammation, a lot of bladder wall damage, and that was what qualified you for an IC diagnosis. However, not much has really changed in probably 50 years, in that people are stumped by the diagnosis and they don't know really how to do anything for you except manage the symptoms.
Okay, so in that case, then, in your opinion, from because you've been doing this for a long time, do you think that it is a much bigger thing than just chronic infection? Do you see it as autoimmune? Do you think it's something related to like missignaling of pain? What percentage of that, because we know we talk about biofilms a lot, and I know that's a big part of it, but if you were to make a pie chart, what percentage is driven by biofilms versus genetics versus the other type of genetics, like the hypercoagulation, the CBS, which we'll get into, and then the mast cells that you're talking about? Can you give us a little bit more of a...
I haven't really parsed it out by those categories because they're cumulative and they're overlapping. So it's very rare that a person would have just one of those. It's usually not A or B or C, but A plus B plus C. So we have all these factors coming together to create the perfect storm in which bladder wall damage is taking place. I had over 1,500 urology diagnosed interstitial cystitis patients. They pretty much at all had negative urine cultures using standard tests. But if I gave them a biofilm disruptor first and then did more advanced molecular testing, and when I say molecular, we're looking for the DNA of the bacteria. I found pathogens, those bacteria that can cause disease, 100% of the time in this population. So was this being driven by the person's genetics? Was it being driven by environmental factors like mold or tick-borne infections or autoimmunity or some combination of all of the above? It just varied from person to person.
Okay, so then let's go into some of those different categories. Biofilms. Okay, that's the one that we really focus on.
Yeah,
So
that's the big
let's
one.
huh?
That's the big one.
That's the big ones. Let's talk about this. What is the well, no, you know what? Let's talk about what is a biofilm. That's probably a
Sure.
very important starting question, right?
Absolutely. Um, about 25 years ago, a microbiologist named Bill Costerton was hired by the oil industry to figure out why they were having petroleum degrading bacteria in their oil pipes. And he discovered that there was this slimy substance harboring petroleum degrading bacteria. And that's why the oil pipes, after the oil went through it, the oil many times was not usable. It had been broken down by these bacteria. And this slime that they found was called a biofilm. And so he published an article in 1999 that showed that if you have bacteria in a biofilm, that it is 10 to 1,000 times more resistant to antibiotics. And so we think of biofilms more like slime, but according to further research since then, the types of biofilms that people have are not slimy. They are more rigid, they are three-dimensional, the bacteria can hide inside of these structures, and these structures can be made up of different components. So the most common one is fibrin that a person makes. And these are long strands that start cross-linking and forming a very tight network that's so dense that it can actually trap not only bacteria but also viruses like COVID. And then we have a certain group of bacteria that are capable of making their own biofilm structures, whether those infections are grown on a culture plate, they're in somebody's sinuses, they're in a prostate, a bladder, a wound. They can construct these structures that embed them in the tissues and make it very, very difficult for the antibiotics to get to where the bacteria really are. And we've not really given enough attention to those biofilm structures. I think the most famous one is H. pylori that is implicated in stomach ulcers. The antibiotics alone don't work very well unless you add something to disrupt the type of biofilm that H. pylori makes. So what I've done is I've taken the information from David Berg, who was looking at certain genetics in which people either make too much fibrin or don't break it down efficiently, and that's 20% of the general population. I've looked at which bacteria make which kind of biofilm and what the literature says is needed to break that down. And now by treating the biofilms with those two pieces of information, I now can make the antibiotics work and we can get rid of these chronic infections that have hung on sometimes for years and years and years. The analogy I like to use is if you think about the soldiers back in ancient times, Greece and Rome, where they had walled cities. and in the middle into the Middle Ages. In any event, if you were trying to get rid of the enemy and all you were doing was killing off the soldiers that came out of the walled city periodically to go get supplies, a raiding party, as it were, and you killed them off, you still had never eliminated the enemy that was all concentrated inside the walled city. And so they figured out back then that in order to be victorious, you had to break down the city walls. And so we had cannons and trebuchet and all kinds of things that were beyond bows and arrows that could effectively break down the city wall. And once you broke down the city wall, now you could get into where the enemy was embedded and kill them off, and you would win. And we have to be just as smart when we attack these embedded infections in the biofilms, that it's not enough just to periodically kill off the small amounts that surface episodically, like, well, I got a new infection. Well, no, you didn't. It was just some of the old infection that was embedded came out of the biofilm. And if all we're doing is putting a Band-Aid on it by killing those little guys when they surface, but never really getting to the main infection inside the biofilm, you're never going to completely eradicate it. So that's the strategy that I've been using, is to figure out which bacteria make what kind of biofilms and which people make their own extensive biofilms.
Okay, so I like that analogy actually very much. So speaking of that, because that seems like the analogy is giving more of that structural protection of the to the pathogens with the biofilm. So is there other things outside of structural with biofilms that protect the bacteria from the antibiotics, like genetically or
Oh,
within the DNA of the bacteria?
that's a very good question. I haven't thought about it in those terms. I think that we're looking at environment of the person. So if you have certain other genetic issues, the environment is going to foster the growth of the bacteria versus discouraging it. So the first thing I can think of is the importance of vitamin D. Vitamin D is needed by the bladder wall to make a peptide called cathelicidin, and that is capable of discouraging urinary tract infections. I had 156 patients who had done 23andMe back when they gave you some decent data, and 100% of them had a vitamin D receptor mutation. So they could make vitamin D from being out in the sun as well as everybody else, but their bodies are never going to be capable of holding on to it because it's a receptor problem. And sure enough, when I checked all these vitamin D levels in these people, they were low. I don't believe the reference range in the US, which goes from 30 to 100, because technically, if you want a reference range of normal people, you want to exclude all the people that have this mutation. And they didn't do that. So I have made the cutoff at 50, not 30. And I have found from experience that if we can get someone's vitamin D level up to 50 and keep it there, they do a far better job of keeping these infections at bay. The second genetic one that affects the environment considerably is CBS, cystathionine beta synthase. There are 24 of those genes. There are a couple of them that I know, Mandy, you've been working on as far as figuring out which ones are maybe more responsible than others. But
Yeah,
the bottom
I've been
line,
trying to keep
yeah,
keep that going.
but it really doesn't matter in some sense if we know exactly which ones are the problem children, because the reality is we just need to know functionally, do you do a good job of taking one of the chemicals that your body produces, cystathionine, and breaking it down well into cysteine, which your body needs to make glutathione to detox, and breaking it down into taurine, which is a non-essential amino acid, not because your body doesn't need it, but because your body's supposed to be able to make it. So you shouldn't have to supplement it. But if you have this CBS mutation, you won't be making enough cysteine, you won't be making enough taurine, and those are going to contribute to some of these infections that we're finding. So the other thing that this mutation does is, we said you don't make a good supply of cysteine, you don't make a good supply of taurine. Instead, you make too much ammonia. And the problem here is that this extra ammonia, the body has to get rid of. And the major way it does that is it sends it off to another pathway called the urea cycle, where your body takes this ammonia and binds it up and puts it in your urine so that the body can clear it. And the problem is, if you either have a CBS mutation or this urea cycle that's supposed to be able to get rid of the extra ammonia isn't working as well as it could be, you end up with extra ammonia sitting in the bladder all night long, because at night your bladder concentrates. It gets less diluted so that you don't get a full bladder and you don't have to get up during the middle of the night to empty your bladder that's full. So you have less quantity in the morning than a full bladder usually, and it's much darker yellow, orange, and that's because it's concentrated. And that concentrated ammonia has been shown to damage the lining of the bladder wall. And this is what is seen on a cystoscopy if a urologist would ever look in your bladder to make sure that it's okay. And when he sees that extensive bladder wall damage, you have now won the IC label. Because it's just a degree of how much damage has been going on over that period of time that your bladder has been inflamed and irritable and giving you symptoms. And so some people have that test done and are given an IC diagnosis. Some people are simply given the diagnosis based on their symptoms and negative urine cultures and treatment failure with a couple of antibiotics that are kind of randomly thrown at you without really knowing what the problem is. So this high ammonia not only damages the bladder wall, but it fosters the growth of certain bacteria that are known pathogens. And so part of my work has been to not only identify what the bacteria are, identify what antibiotic will work best for that bacteria, but saying, let's take that environment and alter it to be unfriendly. And we do that by helping your body clear the ammonia. There's a product, ammonia scavenger, that I'm fond of, and you take that at bedtime, and then in the morning you check your urine pH to make sure it's in that sweet spot of 5.75 to 6.0. How did I decide on those numbers? Well, I saw all the bacteria coming back on the Microgen DX testing, which is the lab that I prefer for looking at these pathogens that the standard cultures are going to miss. And I had a whole bunch of them that really thought a high urine pH was wonderful. And then I had a smaller group of pathogens that tend to prefer a lower pH, but those weren't as common. And I said, I think we have a problem with the pH. If we can lower the pH, these bacteria will not be happy. And sure enough, whereas Enterococcus had been the predominant last guy standing pathogen in over 90% of my patients that we had to treat month after month after month for these bacteria that didn't want to go away. After starting the ammonia scavenger product, lo and behold, I now see Enterococcus less than 5% of the time. And if I do, it's only in scrappy little 5–10% numbers. So here's a perfect example of how you can discourage the growth of many bacteria simply by changing the environment to where it's not friendly for their growth.
So you mentioned Enterococcus. What other bacteria can you, off the top of your head, are very common amongst this population?
Well, some years ago, Microgen collected 157,000 urine specimens
Wow.
from patients that the practitioner indicated had interstitial cystitis or chronic UTIs. They identified about 5,800 different bacteria. So the panel from Microgen that tests for over 60,000 pathogens is going to find what's going wrong, whereas the smaller PCR panels from other companies, they are only capable of checking for either 24. One company runs 2 panels of 24. They have 48 pathogens on their panel. But once again, if you're looking for almost 6,000 different bacteria, a panel of 48 is going to miss a lot of the significant pathogens. And one of the reasons for this discrepancy is, first of all, when they developed polymerase chain reaction, PCR, you have to develop primers for each organism that you want to test for. And if the DNA sequence matches, you've got a winner. Well, if you can only do that for 24 pathogens, how are you going to figure out which ones to choose? And everybody sat around and said, oh, I know, we'll choose the ones we most commonly find on a culture plate. But the problem is that cultures are going to miss a lot of these pathogens. First of all, some of them are slow growing. Some of them have been driven into a cell wall deficient state because of the antibiotics that people have taken long term, which is never a good idea, by the way. And some of these are anaerobes, which mean that they can sustain their life cycle without oxygen. And so even if they're in the urine and they aren't getting oxygen and they go into a specimen cup and then they get put on a culture plate, you've exposed them to oxygen and they will curl up and die. And you'll never find them on a standard urine culture plate. So what we're finding on the Microgen reports is that a number of these pathogens are anaerobic, and you would have never cultured them out on a standard plate, or they're a facultative anaerobe, meaning that they have the ability to switch back and forth between sustaining their life cycle on oxygen or without oxygen. And so once again, the diagnostics here are just not good enough for the chronic population. The literature says that 99% of UTIs are caused by E. coli, but the culture plate favors the growth of E. coli. And in this testing that they did with this 157,000 specimens, they found that the predominant organism, the one that there was the most of, was E. coli only 28% of the time. So that means the other 72% of the people that are being told that their culture was positive for E. coli, and that was the problem, 72% of the time it was really a different pathogen that was the major trouble causer.
Yeah, we've seen that on some of the tests that we reviewed together, where there's these bacteria that are not, never heard of them before. They're not the common things that you hear on cultures. They're,
No, and you
they're
can't
odd.
pronounce them.
Yeah, you can't pronounce them, and they're odd. They're like I had one that wasn't. I looked it up. It was an aquatic organism. Like, I don't know how
Mhm.
I got that. Maybe from the ocean. I don't know.
I don't know, but I see a lot of things
Yeah.
that typically are not reported in the literature because the cultures miss them.
Right, that makes a lot of sense, especially if they're using the culture, some of these smaller panels are using the cultures as their benchmark of which organisms to test. Yeah, they're
Yeah.
just basically repeating the test, just using a different type of test. Interesting. Okay. I didn't know that about Microgen, that they tested that many organisms. That's very, very interesting.
Yeah.
Okay, so that answers that question
Can
of,
I add one
yeah,
PS to
yeah.
that? In that panel of 60,000, they are also checking for fungal infections or yeast. if you send a specimen to a commercial lab and yeast grows, they tell you it's contaminated. Whereas for maybe as much as 10% of the chronic UTI IC population, fungal or yeast is growing in the bladder. It is part of the biofilm. It can make people every bit as symptomatic as bacteria, and they are not identifying it, and therefore they're not getting it treated.
Interesting. Wow. Yeah, I definitely have seen that on the test that I've run. Interesting. Okay, so we talked about the biofilm of the organisms. So okay, so regarding microgen, so E. coli is not the most common. Enterococcus was. Is that correct?
It used to be
Oh,
until I figured out about clearing the ammonia. And then we started seeing predominantly Klebsiella and Enterobacter. And those are kind of unique because they don't really care about the pH. They'll be happy from 3.0 to 10.0. So we aren't going to adjust the pH of the environment, and they will be happy to grow no matter what. These tend to come from the GI tract. And so I started doing some more research, and lo and behold, NIH 3 years ago published a fascinating article talking about using taurine to get rid of Klebsiella colonizing a person's GI tract and helping, it's not the only thing you need, but helping to get rid of Klebsiella in the urinary tract. It also has the benefit of helping to stop the bacteria from attaching to the bladder wall. And so we started using this in addition to the antibiotics and the biofilm disruptors needed that Klebsiella and Enterobacter make, and having really good success. They still tend to be harder to get rid of than some of the other pathogens, but we are getting rid of them. This is an interesting case, once again, of why you need molecular testing. There are many different species. For instance, maybe a PCR test will identify Klebsiella pneumoniae, but it probably won't have Klebsiella oxytoca on the panel, and it certainly won't have Klebsiella granulomatis on the panel. And so if you miss those, they need different antibiotics to treat it. And if you're only identifying the pneumoniae, you may not be getting a good result from treatment. The other thing that's concerning to me is that some people have what's known as Hunner's ulcers. They're ulcerations in the bladder wall. Just like H. pylori is responsible for stomach ulcers, I have a suspicion that this Klebsiella granulomatis could be a contributing factor to Hunner's ulcers, because when you read about it, if it's in another place as part of the infection, like a skin infection, it will cause ulceration. So it's really important that we know exactly what pathogen is there that comes out of the biofilms when we start to disrupt them, and that we then treat them appropriately, so that it doesn't get missed and they're given the wrong antibiotic.
okay, good. Interesting. Very good information. So let's switch gears here a little bit here. Hypercoagulation. I love this
Ah,
one. Let's talk about that. What does it mean? Define it.
sure. Um, Once upon a time, people wondered why blood clots formed. And so they started looking at the pathway in the body that makes blood clots. And they called this the coagulation pathway. And mostly they were concerned because we had a certain number of people who were bleeders. They had hemophilia, they had a bleeding disorder. And so those were the first genetic problems to be identified. Um, about 20, 30 years ago, a brilliant scientist, lab person, David Berg, opened Hemex Lab. And because of his personal experiences with heart attacks and clotting issues, started investigating what were the genetics that were responsible for why someone would be more prone to making a clot. And this has had really big implications because 20% of the general population genetically either makes too much fibrin or they don't break it down efficiently. And fibrin is the main component of a blood clot. That's what makes the network that traps the red blood cells that forms a blood clot. You see that when you get a scab, when you get a cut and a scab forms. It's that fibrin that's interlacing, that's trapping the red blood cells. Well, it turns out that that fibrin can also get thicker and more dense over time and become, if it's really abundant because you're one of those people that makes too much or doesn't break it down well, then it starts trapping bacteria or viruses, and your infections, instead of responding like everybody else's to the short course of antibiotics, months, years later, you're still struggling. This is the situation with long COVID. 20% of the general population has one of those genetics, and 20% of the people who got the more virulent forms of COVID ended up with long COVID. I'm very suspicious that I know what those genetics are. So we have this extra fibrin going on, and what makes this even more concerning to me is because I have people on both sides of my family. All four of my grandparents died of heart attacks or strokes, and so did my parents. And I've had a history of blood clots and interstitial cystitis and miscarriages. And so figuring out those genetics for me was really important on my personal journey. And in my chronic UTI-IC population, I found one of those 4 genetic problems 70% of the time. And it turns out that extra fibrin not only can trap red blood cells for a clotting event or bacteria for a chronic infection, but it starts accumulating inside the arteries, trapping cholesterol. You get atherosclerotic plaque, narrowing of your arteries, and therefore you end up with a heart attack, or if part of that plaque breaks off, you can have a stroke. So this hypercoagulation piece has a lot of implications beyond just your bladder or your prostate. When I did family histories of these patients, most everybody who knew their medical history for parents and grandparents did have someone with hypertension or heart attacks or strokes, cardiovascular disease, and this was probably because of their genetics that they inherited from their parents and grandparents. So I'm pretty excited about this hypercoagulation testing that can be done through LabCorp. It tells you how much fibrin you're making in real time, how well your body is breaking it down. It looks at the 4 genetic problems that can contribute to this. And once you have that information, then you know whether you need certain interventions to slow down your production of fibrin, or whether you need more fibrinolytics or supplements that will help you break down the fibrin, as well as the other 80% of the people on the planet. We are not anticoagulating anybody, okay? Even if we're slowing down how much fibrin your body is making with an anticoagulant, you still are not anticoagulated, you're just normalized. We've just made your fibrin production the same as other people. If we're giving you a fibrinolytic like lumbrokinase, something to break down the fibrin, once again, it is not an anticoagulant. It'll never cause spontaneous bleeding. All we're doing is helping your body break down that extra fibrin so you have a normal amount just like everybody else. And that means you won't have that extra fibrin causing a clotting event, causing infections to become chronic, or setting you up for cardiovascular disease later on.
This is interesting. I found a couple of things you said. 20% of the population, but 70% of the IC population. Really interesting. You mentioned fertility with the miscarriages. This makes sense because a lot of the patients, when they come to me and we start working on the biofilms and treating them, they get pregnant
Yep.
and they don't have
Yep.
the, I had several of them that were having repeated miscarriages and they stopped having miscarriages and they had the baby. And that's making a lot of sense
Absolutely.
now.
Absolutely. And what happens is because pregnancy is a hypercoagulation state, is that if you have trouble, if you end up making too much fibrin, or if you have trouble breaking it down, that placenta clots off, usually in that 6 to 12 week period. And that can be totally avoided once you know these genetics and you can take the appropriate intervention to have the right amount of fibrin being produced throughout the pregnancy. Um, it's kind of a complicated pathway with many different parts, but getting the basic workup to know if you have a genetic component contributing to your biofilms will make a huge difference in the ability to break them down so the antibiotics will start working. And it will pay off big time in the long term with preventing cardiovascular disease. We've had many, many patients who've had a lot of this fibrin building up in their arteries, particularly postmenopausal women. There's a certain test that can look at your coronary artery calcium buildup. We've had people come back with it being in the hundreds, and after a couple years of the lumbrokinase as a fibrinolytic, their retest scores are 0. That's what happened to me.
That's amazing. 0.
Mm-hmm.
Wow. Is it safe to take during pregnancy, lumbar kinase?
That's the right question. There is a white paper showing its safety. I've had many, many patients taking it at least through the first to get through the first trimester of pregnancy. I think this is a safer option than the aspirin that some OBs are recommending. This is a fibrin problem. It is not a platelet problem, and aspirin works on platelets. Aspirin can also cause GI bleeding. Lumbrokinase never will do that. So the recommendation that, from my standpoint, based on the research that I have and experience, is that women stay on the lumbrokinase for the first trimester. And then if they have one of these genetic issues or a history of miscarriages, that they can be put on Lovenox for the rest of the pregnancy. We don't want to stay on the lumbrokinase because it takes 3.5 days to get out of a person's body. And when you go into labor, you can quickly reverse Lovenox, and you can't do that with lumbrokinase. And we don't want to postpartum hemorrhage because we've slowed down the clotting mechanism by reducing the amount of fibrin that's circulating.
Okay, good. Good information. All right, let's go into the gut because you did mention Klebsiella. So what's
Yeah,
the connection between gut dysbiosis and recurrent bladder infections?
well, everybody is really big on the wipe front to back, wipe front to back bandwagon because we all acknowledge that there isn't a whole lot of real estate between your rectum and your urethra. Um, I think my bigger concern for most women is that between the rectum and the urethra, we have a vagina. And I have many, many patients that when we do the initial testing with microgen, we do the urine, but we also do a vaginal swab. And probably half of these women have a lot of bad pathogens in their vagina that they either got from a sexual partner or from the GI tract. And those will continue to seed into the bladder unless those get addressed by making the environment unfriendly, by acidifying the vaginal tract further, um, removing the source of the, or not removing, identifying the source of the reinfection, which could be getting the sexual partner treated, or by getting rid of the pathogens in the GI tract. Once a GI tract is colonized with some of these pathogens, it's going to take months of herbals or adjusting with some other supplements, the environment, so that these pathogens are no longer flourishing. For the Klebsiella as the predominant pathogen, I had a number of patients who had had GI maps done by their practitioners. When we looked at them, all but one had an overgrowth of Klebsiella in their gut. So there was no doubt in my mind where the Klebsiella was coming from, because I didn't often see it in the semen of the sexual partners. So getting the gut flora optimized, normalized is a piece of the puzzle for many, many patients. Interestingly, with the Klebsiella, the taurine is making a huge difference. I had one lady who had been coming back with Klebsiella for month after month after month for 9 months, no matter what we did. And I read the article on the taurine, got her on 3 grams twice a day. And lo and behold, the next report for the first time in 9 months came back, no Klebsiella. And she kept it away for 4 months. And then I got real cocky and said, let's back off and just do a real low maintenance dose of taurine. And it came back. But since we've had her on the higher dose, she has not had the Klebsiella return. And that's been over a year.
Very interesting. Okay. So that's really nice to hear, because we're going to talk about antibiotics now, and this is a nice way to manage it and treat it, because we are seeing a rise of antibiotic resistance. So this is a problem. So what do you do with these people who have failed multiple rounds of antibiotics? What's the strategy?
Um, First of all, I want to clarify that antibiotic resistance is carried by the bacteria themselves, not by the person. And people who've been on multiple courses of antibiotics, and all they did was treat the little raiding parties that were coming out of the biofilm, because they weren't doing biofilm disruption. If there were any survivors, they went back into the biofilm and taught everybody else to be resistant, because they talked to each other with quorum sensing. So these antibiotic resistant bacteria can be really, really deeply embedded in the biofilms. So we might have a report coming back one time not showing any drug resistance, but because we're continuing to give a fibrinolytic, lumbrokinase, until all the infections are gone, and maybe the rest of a person's life, if genetically they need extra help breaking down the fibrin.
Which 70% do. Right.
Well, no, there's a few people that it's they make too much, but yes, I agree. So they these bacteria that are embedded in the biofilms that finally surface may be carrying some of these resistance genes from antibiotics that you as a patient took 5, 10, 15 years ago. These bacteria have not forgotten that they were exposed to this antibiotic in a subtherapeutic dose. And so we might see no drug resistance this time, but then the next time we test, we might see a whole new crop of bacteria we didn't see before, and we see a whole bunch of drug resistance genes. Well, that person hadn't seen 4 new antibiotics in a month. This is old resistance genes carried by those pathogens. But the good news is when we treat those pathogens with an antibiotic that it isn't resistant to, and we get rid of them thoroughly because we're knocking down the biofilm walls, those drug resistance genes go away. So basically 100% of the time, there is no drug resistance genes left when we've gotten rid of all the infections.
People listening need to understand what she's saying here, okay? Because this is the number one problem I encounter. You have to repeat the test. You can't just treat and not repeat it. I mean, what I'm hearing here is to get this done, get it in and get out. Like, I think sometimes people drag it out because they don't want to repeat the test. You got to repeat the test. You got to treat, you got to repeat, you got to treat, you got to repeat. And the people who do, they're the ones who get to that end game, which is to get rid of these bacteria that are producing these drug resistant genes. Now, speaking of antibiotics, is there other natural antibiotics that people can take alongside? Are they as effective as antibiotics? I get this question a lot, so I think it's important to talk
Oh,
about.
of course. Um, I know that Stephen Buhner did a lot of really excellent work with herbals. And in his one book, he even identifies which herbals work on which bacteria. I was so excited about that. I had talked to him. I don't know if you knew he had died a couple years ago, but he and I had conversations about this, and it seems like those work just fine unless we have a biofilm involved. And when you're looking at biofilms, it becomes a different ball game because now we have the city wall. And um, I wish we could do it without antibiotics, but I haven't found an herbal protocol that's as effective. I've had some practitioners use some of the herbals along with it. I can't tell you, I have no way of knowing whether it adds an additional 5, 10, 15, 20, 30% goodness to the equation or not. I honestly have no way of measuring that. I will tell you that now, once I know what biofilm the pathogen does or does not make, and I know which additional supplements work on those particular types of biofilms. And we have waited until a significant amount of that pathogen is showing itself. It's very rare that I can't get rid of an infection within 1 or 2 courses of antibiotics. And I usually treat for 2 weeks at a time. Um, the issue here is with biofilms is just like one cannonball isn't going to destroy the whole wall. One course of biofilm disruptors in one test isn't going to show us the total story. And that's why you keep retesting. You get the bugs on the run. You don't want to give them time to rebuild the wall.
I know this is really hard for a lot of people because, it's a lot, it's huge investment, not just financially, but also time. And, I think they don't want to be on the antibiotics as much as, they need them for that and I tell them it's a short time of your life. It's not like you're going to do it for 10 years. Let's hope not. But, I mean, that's something I wanted people to hear. You do have to retest. You have to. It's the same with the HTMA. When I do the hair testing, I've retested in 6 months because you don't want to be on the same supplement. Your body changes. So is there any other therapies that are in the pipeline, like immunotherapy I hear all these things. I haven't been up to snuff on all this. What do you talk
Sure. Let's talk about phage therapy and immunotherapy, or not immunotherapy, the new vaccine, neuroimmune. That's it. Um, Phage therapy requires, number one, that you can actually grow the bacteria on a culture plate. And we've already discussed why that isn't going to work for a lot of the pathogens that we find. Secondly, then they make up phages, and they do seem to really be helpful, but it's limited. We're talking 3 to 6 months. I had patients who used to fly to the country of Georgia, and for a while there was a place in the United States that was doing phage therapy. And I think that it has some help, but I didn't see it having long-term results. There's a new vaccine out, Euroimmune, that's getting quite popular in Europe. And under the mistaken impression that 99% of UTIs are caused by E. coli, that's the main one they target. They also have something in it for enterococcus, and I think there's 2 other pathogens that they also have in the vaccine. Once again, it wears off. It knocks it back temporarily, but the issue is if you haven't fixed the pH of your urine, in which those bugs are going to flourish. If you haven't gotten your vitamin D levels up, if you haven't worked on the biofilms, once again, we're not breaking down the city walls. We're not getting to the where the main bulk of the infection is living, which is in the biofilms. And by the way, you can spend a heck of a lot more on phage therapy and some of these others than you would ever spend in a year doing microgen testing and getting treated for the pathogens identified.
Oh, financially,
Yeah.
and this is excluding the cost of traveling.
Yes. Oh, yeah.
What
And
does it run for? Do you know what it goes for?
I don't have any current pricing, but I do know that it may be a short-term investment with short-term results, but do you want only short-term results or do you want long-term results? Because once we've eradicated these infections, the bladder wall can now heal. It takes 4 months for a damaged bladder wall that's infected to repair.
Oh,
But it's just like a cut on your arm. If it's infected, it's never going to heal up as long as the infection is going great guns. And so you have to treat the infection, and as you treat it, the bladder wall can start to heal. And people notice a difference. I mean, even though it might take 4 months for the bladder wall to completely repair, people, as we lower, course after course after course of antibiotics, in the first 4 months, they're noticing, well, maybe I only get up twice at night to urinate instead of 4 times. If I have a major flare, instead of it putting me out of commission for 3 days, maybe it's only a half a day or one day that I'm not functioning well. Um, Foods, if their bladder is diet sensitive, which many IC patients have enough bladder wall damage that certain foods really set it off. I mean, I was so bladder sensitive, one grape and I could be up all night long. So, I mean, this really is an issue diet wise with you look at certain foods and you feel pain because you know what's going to happen if you touch it. But maybe they can start eating some of these foods again in small amounts and their bladder doesn't complain. And those are all signs that you're on the right track, that your bladder wall is doing the repair work, and that you are going to get there. But you're not going to get there if you leave some of that bacteria still there to sit around and multiply for a couple of months before you retest again.
right. That's
That's
again
not good
important.
military strategy. You
I
get the
know.
enemy on the run and you keep pursuing.
Thank you.
You don't decide, oh, well, I killed off some of the guys that came out of the biofilm this time. I think I'll go home and rest for a while and not deal with anybody else.
Right. Right. Great advice. So once somebody is in long-term, yeah, I guess I'll call it remission, and infections are under control, we have all these mutations, right? We have things that we're going to deal with. We have, let's say we have a CBS, we have the Pi 1, where we're going to talk about the hypercoagulation, we have a VDR. We've already had a few infections, so our body has already been there. What should people do? And I'm even considering hygiene as part of that conversation for long-term care.
Um, well, yeah, this could be a long list depending upon the person. The easiest thing to do is keep your vitamin D level above 50. And please do not be fooled into thinking just because you decided to go out in the sun every day over the summer, you didn't need to supplement. It's a receptor problem. I did an experiment on myself and I failed. My level was 61. At the end of May, I went out in the sun every day all summer long, and in September, my vitamin D was 32.
Whoa.
So the answer is, if you have had a low vitamin D level, don't expect to be able to bring it up by just sun exposure. And by the way, sunscreen, even SPF 15, reduces vitamin D production by 87%. So, I don't want anybody getting skin cancer because they were foolish. but I also want you to know that if you're going to supplement to keep your levels where it needs to be, that has to be year round. The second thing is keeping the urine pH in that nice safe range of 5.75 to 6.0. This will go a long way in preventing a lot of bacteria, the E. coli and the Enterococcus, and a lot of other nasty guys from having a happy home. The other thing is the fibrin production or breakdown. Depending upon your genetics, there will be certain things you will need to take to normalize your fibrin. Like I said, we are not anticoagulating you. We are just simply helping your body make the appropriate amount of fibrin and or break it down as well as other people break it down. I've had some interesting reports from patients who said, yeah, I got on the lumbrokinase and it usually takes an hour for them to fill up the tubes when I get a blood test done, and I filled them up in less than 3 minutes.
Oh, interesting.
So their blood isn't trying to coagulate as quickly. The other thing that many women notice is that their periods become normal. By normal, we mean menstrual blood should not be clotting. If you've ever had a history of clots with your menstrual flow, that is very suspicious that you have one of those genetic issues. You probably have more cramping with your periods because those clots have to squeeze through a closed cervix. So if you have had a lot of clotting with periods, if you have had a lot of cramping with periods, getting this testing done could be a huge game changer. Because if you're on a fibrinolytic, then your menstrual flow should be normal and you won't have the clots or the clots causing cramping trying to pass the cervix.
Oh, very interesting. I didn't know that about the cramping. Huh?
Yeah. So, and we're not saying it's true 100% of the time or that's the only cause, but I'm just saying many, many patients, once we've put them on the lumbrokinase because of their genetics, start reporting that that whole issue has become a non-issue.
So really, you have to know what you have going on before you can do that. I mean, you have to get your genetics tested. I mean,
Oh, yeah.
yeah.
I mean, and this is important because if you have siblings, you have parents, you have children, this is genetic.
Mhm.
So if you come back with one of those mutations or deletions, there's 4 of them, then the rest of your family needs to know for their health, long-term health.
Yep. Well, thank you so much. This is really great and very informative. And I think it'll be great for, people who are just new in this to understand what's going on. And I
Yeah.
really appreciate you being here today.
Well, thank you
And
for
is there any where people can, if practitioners are listening, where can they find you?
Sure. RuthKriz.com takes you to my website. It is being newly constructed, so there's not as much information there quite yet as we would like, but on it is a provider selection tool on the top bar, and it has the list of practitioners that I've been working with and training in most states and a number of countries. If you want to find a practitioner, who can help you with some of this testing. Mandy's been doing a lot of the testing and can help you as well. But this is a big deal to know that you don't have to live like this the rest of your life. These conditions are treatable, they are curable. We can get your life back, but just because you didn't, well, first of all, you didn't get here overnight. It was a process over many years. It cannot be reversed. There is no one and done. And just to reinforce the point that you test, you treat, you retest, you retreat, and most people in less than a year have their lives back. There are certain complicating factors like tick-borne infections and mold toxins. And one of the genetic problems, which is a high lipoprotein little a, a form of bad LDL cholesterol, if one of those 3 is complicating the matter, it could take longer than a year. But without those 3, most everybody is well in under a year. So I think it's a good investment with the right support.
I agree. And it does affect men too, by the way. So those listening, it's not just women.
Absolutely. And I will tell you, the men that's being affected, we do a men's key kit, which is both semen and urine. The reason it gets in the bladder of men is that they have retrograde ejaculation. And if you're only testing the urine, you probably aren't going to be given the right antibiotic that has good prostate penetration, where the infection is based, that walled city in the biofilms in the prostate, and you probably won't be treated long enough. And so UTIs in men likewise require additional testing, not just the urine.
Correct. Yep. All right. Well, thank you. Wealth of information. Then thanks for being here.
Oh, this has been great, Mandy. Thank you so much for having me.
Thank you.